Welcome to our bone chapter. In this sketch, we're going to illustrate a couple of diseases with overactive osteoclasts, the supremely common osteoporosis and the supremely rare Paget's disease of bone. Come join your classmates on a trip to this bone-chillingly awesome museum. Bone is a dynamic living tissue. As represented by this perfectly balanced scale, bone homeostasis is actually achieved through a balance of bone formation and bone resorption. And this is because of some really cool cellular players and molecular pathways we're going to tell you about. Let's meet the cellular players. Osteoblasts are the bone builders. They also play a key role in the regulation of bone mineralization. Osteoclasts, on the other hand, break down bone. Notice how we've made these classmates here playfully break down the spirit of this poor guy? Well, think of osteoclasts as your bone's relentless little scavengers. Osteoclasts actually make special enzymes that break down and resorb bone. Neat fact, the osteoclasts arise from the same cell as the macrophage. Osteocytes are found within the bone. They associate in a network of tunnels called canaliculi. We've symbolized these cells with the museum translator here because osteocytes process mechanical input and translate them into biochemical signals. Neat. Okay, full disclosure, we have to go over a bit of molecular physiology. So let's meet our molecular players. RANK stands for receptor activator of nuclear factor K. We've depicted it by this rank amateur kid who definitely should not be handling this drilling tool. Come on, kid, let's leave the heavy machinery to the professionals. This receptor is expressed on osteoclast precursor cells, so we have this classmate here wielding the power tool. When bound by a special ligand, RANK activates the osteoclast. And this power tool, or crank, represents the special ligand for the RANK receptor, i.e. RANK-L. RANK-L stands for receptor activator of nuclear factor K ligand. That's quite a mouthful, so let's just stick to RANK-L. This ligand is actually expressed on osteoblast cells, and doing what ligands do well, it binds to the RANK receptor on osteoclast cells and activates them. As you can see by our rambunctious classmate, if left unchecked, ligand-bound RANK can wreak havoc on your bones. Enter osteoprotegerin, or OPG for short. OPG modulates the binding of RANK and RANK-L and controls osteoclast activity. OPG is normally made by osteoblasts, which is why we have our bone builder here holding this OPG case. And you may notice that the crank is missing from the case, but don't worry, this is a play crank. The perfect decoy to hopefully distract the classmates away from the real priceless artifacts. Much like this play crank, OPG acts like a decoy receptor that binds up and hides circulating RANK ligand. Trapped ligand can't properly bind RANK, which means the osteoclast switch remains in the off position. Pretty clever, right? Osteoporosis, or as it's referred to in Greek, porous bones, is a metabolic bone disease characterized by abnormal loss of bone mass with normal bone mineralization, calcium, and phosphate levels. Now, we're going to get into risk factors in a moment, but first we want to clarify some misinformation you may notice in texts, journals, and lectures. Race is not a predictor of osteoporosis. Put simply, race is a social construct. It's not biological, and therefore there is no basis for concluding that certain races have higher bone mineral density than others, and therefore decreased risk of osteoporosis. In fact, because of socio-political disparities, the evidence is clear that Black patients face worse outcomes related to osteoporosis, such as severe falls and fractures with longer hospital stays, long-term disability, and higher death rate. So, what does put an individual at risk for getting osteoporosis? Let's start with the age effect. Bone mass increases during childhood and into adulthood, peaking somewhere in your 20s or 30s. After the brief honeymoon period, between ages 30 and 40, bone resorption starts to exceed bone production, and the slow downward slide of bone aging begins. It's thought that senile osteoporosis develops as the bone-forming osteoblasts lose their functional activity. Meanwhile, the bone-eating osteoclasts continue to work just as hard as they always have. Taken together, this leads to decreased bone formation and increased bone resorption. Another factor that may play a role in the pathogenesis of senile osteoporosis is a decrease in weight-bearing activity as people age. Besides age, hormones like estrogen, thyroid hormones, parathyroid hormone, and cortisol also influence bone turnover. Why estrogen? Well, high levels of estrogen act to decrease osteoclast activity and increase bone production by osteoblasts. But what happens when you put all that on pause? Well, the drop off in estrogen levels, which occurs in cisgendered women who undergo menopause or in transgendered women who discontinue exogenous estrogens, is associated with an increase in the pro inflammatory cytokines IL 1, IL 6, and TNF alpha. These cytokines increase bone turnover by recruiting osteoclasts and decreasing osteoclast apoptosis. Additionally, rank L expression on the surface of osteoblasts is increased. These cytokines also decrease the normal production of osteoprotegerin by osteoblasts. All of these factors combine to increase osteoclast activity, increase bone resorption, and decrease bone mineral density. There are also a few endocrine disorders that can lead to decreased bone density. To remind you of cortisol, we've placed our recurring moon face symbol. And this will help you remember that excessive endogenous cortisol from the adrenals in the setting of Cushing syndrome can cause osteoporosis. And for all the common signs and symptoms of glucocorticoid excess, check out our Cushing syndrome sketch. Let's learn about the effects of PTH with the help of our PTHD professor. Hyperparathyroidism is characterized by an excess of PTH, or parathyroid hormone, which leads to increased activation of osteoclasts and, you guessed it, osteoporosis. Be sure to check out our Ice Cream Lab parathyroid sketch over in the food court for more info on the specific bone findings in hyperparathyroidism. That leaves us with one more hormone to mention, T4. So we've added our patented red bow tie to the professor's ensemble. Excess thyroid hormone, either due to intrinsic hyperthyroidism or excess intake of levothyroxine, can stimulate osteoclasts to resorb bone, thereby increasing risk of osteoporosis. There are also some lifestyle factors we should mention here. We're talking about diet and exercise. Mechanical forces promote normal bone remodeling. Activities that load up the bone, like weight training, help to maintain a healthy bone mass. So, to help you remember it's the lack of bone loading that causes osteoporosis, we have our professor here taking a load off. Yeah, professoring is hard. Okay, so pumping iron may help strengthen your bones, but diet, on the other hand, doesn't have as clear of an association with osteoporosis. You may be asking yourself, but doesn't milk do the body good? Well, that's not totally the case when it comes to osteoporosis. Remember, osteoporosis is marked by normal bone mineralization, so calcium and phosphate levels are actually normal. That said, adequate intake of calcium and vitamin D in the adolescent and adult diet is an important determinant of peak bone mass. There are some secondary causes worth noting, like certain medications, cigarette use, and alcohol consumption. And we've depicted this grab bag of risk factors with this mortar and pestle. Corticosteroids, such as hydrocortisone or prednisone, reduce bone density via several mechanisms. First of all, steroids increase production of rank L and decrease production of osteoprotegerin. Gee, that sounds a lot like what happens in estrogen discontinuation or decline. Now, if that weren't enough, corticosteroids also decrease estrogen production. The pattern of bone loss with corticosteroids is an initial period of rapid bone resorption, and if used chronically, the balance is shifted towards decreased bone formation. Steroids can actually affect bone density after only a few short months. In addition to steroids, lots of other drugs can cause decreased bone mass. Let's go over a few examples. Use of depoprogesterone puts the body in a low estrogen state, hence the broken estrogen necklace here. The loss of bone mass is most prominent in the first couple years of therapy, but tapers off over time. That said, any losses are virtually reversed when the patient stops taking the drug. Other potential culprits in your medicine cabinet include anticoagulants such as heparin, and proton pump inhibitors, and anticonvulsants like phenytoin and carbamazepine. Cigarette smoking is bad for your health for so many reasons. And it can even affect your bones by inhibiting osteoblast activity, which shifts the balance of bone remodeling towards osteoclastic resorption and reduced bone density. Heavy alcohol use is also associated with lower bone density and an increased risk of fractures. Not to mention it can increase the likelihood of falls. Bone loss isn't really an all or none thing. Actually, there's a spectrum of abnormal bone mineral density, starting with osteopenia and going all the way to osteoporosis. Let's get into the details. If you'll draw your attention to the wall here, you can't miss our whale of a symbol for osteopenia. Osteopenia just means decreased bone mineral density, technically one standard deviation below that of a young, healthy adult. Osteoporosis, on the other hand, is a severe form of osteopenia characterized by even greater bone mineral density loss, disruption of bone microarchitecture, and bone fragility with an increased risk for fractures. Okay, histology time. So, what happens when we start losing bone? Well, first recall that there are two main types of bone: cortical bone and trabecular bone. Cortical bone is the dense, compact bone that makes up the outer layer, while trabecular bone, aka cancellous or spongy bone, is at the ends of the long bone, deep to the cortical bone. It also makes up the shoulder blades, ribs, and vertebral bodies. Histologically, osteoporotic bone will show normal cells with normal mineralization. In other words, don't expect to see abnormal bone, just merely less bone to go around. Cortical bone also shows changes. The cortex is thinner and the Haversian canals are widened. And trabecular bone gets smashed, so that means thinner and fewer connections between trabeculae. Think of it as being even spongier. So, how does all of this look, clinically speaking? Well, decreased bone density means a higher risk of fractures. Osteoporotic fractures are also called fragility or pathologic fractures because they occur as a result of weakness of the bone in the setting of a fall from standing height or less and not from some severe extrinsic force, like a car accident. Compression fractures of the vertebral column are the most common fragility fractures in patients with osteoporosis. These are typically in those weight-bearing thoracic and lumbar vertebrae, and essentially never seen in the cervical region. Each individual fracture is usually asymptomatic. Over time, however, multiple compression fractures can lead to a noticeably shorter height. Notice the exaggerated curvature in the skeleton here. Excessive kyphosis of the spine from compression of the anterior aspects of the vertebral bodies can lead to a stooped-over posture called Dowager's hump. Fracture of the distal radius, also known as Colles fracture, is another common fragility fracture in the elderly caused by falling on an outstretched hand. This large dinner fork will help you remember the classic dinner fork appearance on X-ray, which is a dorsal displacement of the distal radial fragment. Another fracture commonly seen in osteoporosis is that of the femoral neck, usually caused by a fall onto the hip. The fracture usually occurs at the surgical neck. You know, that thin extension next to the ball and socket joint. In advanced osteoporosis, the cortical bone is so thin that even a fall from standing is enough to crack it. Yikes! All right, diagnosis time. In the absence of a fragility fracture, osteoporosis is diagnosed by directly measuring bone density with a DEXA scan, represented by this bone in DEX book here. The DEXA, or dual energy X-ray absorptiometry scan, if you're fancy, is a non-invasive X-ray imaging technique performed at the most frequent sites of fracture, the hip and lumbar spine. T-score, let's see here. T. Ah, yes, here it is. The triquetrum. That's definitely what this is. In order to interpret the results of the scan, we calculate a T-score. The T-score tells you how your patient's bone density compares to a young adult reference population. Specifically, how many standard deviations above or below. And these bones here spelling out the number 2.5 should clue you into the cutoff we use for normal bone density. About 2.5 standard deviations below the norm. However, keep in mind, even if you're above a minus 2.5 T-score, if you get one of these fragility fractures, that's osteoporosis by definition. With osteopenia, think zebras for Z-score. A Z-score compares your patient to a population of the same age. The cutoff is minus 2. That means your patient falls 2 standard deviations below others who are of the same age. In a young person, this is a red flag for unintended drug effect or potential substance misuse. Once you diagnose osteoporosis, there are ways to manage it. Treatment of osteoporosis is multifactorial. It involves adequate calcium and vitamin D intake, incorporating weight-bearing exercises, and pharmacotherapy, symbolized by Sketchy's bisphosphonate donation box. Bisphosphonates inhibit osteoclast activity and slow down bone resorption. And don't forget to put a 10 in for calcitonin, which inhibits osteoclasts and is great for postmenopausal osteoporosis. For more detailed information of these pharmacological therapies, see Sketchy Pharm. Okay, that's it for osteoporosis. Let's conclude our story with another disorder of bone metabolism. But this time it's the osteoclasts and osteoblasts that are out of control. We are talking Paget's disease. Of bone, that is. This Paget guy discovered a bunch of different diseases, actually, and then he proceeded to stamp his namesake on them. Another name for Paget's disease of bone is osteitis deformans. But here at the museum, we just call him Homo Pagets. Whoa. Hold the bone. Is that thing assembled right? I mean, I barely know my coccyx from my Christogalli, but even I know that the head is upside down. Otherwise, looks good. In general, Paget's disease is characterized by rapid bone turnover and grossly enlarged but structurally weak bones. More than 140 years after Paget first described the clinical findings of osteitis deformans, we still don't really know what causes it. Current thinking is that it's likely a multifactorial combination of genetic predisposition, environmental factors, and possibly even infection by viruses such as paramyxovirus or measles. Let's go over the histology. Paget's disease can be broken up into 4 phases: lytic, mixed, sclerotic, and quiescent. Okay, let's get into them. The first is the osteolytic phase, which involves a bunch of overactive bone-eating osteoclasts, represented here by the wild osteoclastmates grabbing a bunch of bones from the bone box. The osteoclasts do what they do best: resorb bone, creating little resorption pits. You'll even see a bunch of huge multinucleated osteoclast cells. Next up is a mixed phase, where both osteoblasts and osteoclasts are active. This mixed phase leads to bone turnover and pretty disorganized bone building. Look, guys, I'm pretty sure you got the left and right arm switched. Or something. The third stage is the osteosclerotic phase, where osteoblasts take over, producing bulky bone. Just leave it to the professional osteobuilders, kids. During this phase, histology will show a disorganized mosaic pattern of woven and lamellar bone and prominent and haphazardly arranged cement lines. This mosaic pattern is pathognomonic for Paget's disease. Finally, things quiet down and the bone enters a quiescent, aka burned out phase, where, as you can guess by the name, not much really happens. Okay, let's go over a few clinical features. The finding of an enlarged skull is a classic one for Paget's. In fact, it's been seen in human remains that are thousands of years old. In the question stem, keep an eye out for a patient who complains that his hats don't fit him anymore. Patients may also complain of associated headache or dizziness. Hearing loss is another common symptom due to involvement of the cochlea. What do you say, Mr. Tiny Hat Skull? What do you say, Mr. Tiny Hat Skull? Gets me every time. Remember, these Paget bones are bulky but weak. In fact, they don't handle stress loading well, and the bones of the lower extremities can become deformed and bowing with asymmetry. Over time, this can lead to severe osteoarthritis. Also, weak bones are prone to fractures. Long bones may suffer a so-called chalk stick-like fracture that looks like a broken piece of chalk. While most patients with Paget's disease of bone live long lives with little disease burden, less than 1% of patients will develop malignant osteosarcoma. So we've placed our patented cancer crab here to remind you of this bone cancer, which typically occurs in patients with long-standing Paget's disease. There are some manifestations occurring outside of the bone, too. An important one to know is high-output heart failure, represented by a recurring floppy heart balloon. In the early phase of Paget's disease, there's hypervascularity in order to meet the needs of the active tissue. With more extensive disease, this hypervascularity leads to high-output heart failure. These are textbook findings, though. Practically speaking, the majority of patients are asymptomatic, and cases are discovered incidentally after abnormal lab findings or imaging. Patients may complain of bone pain, most often as a result of fracture or from nerve compression. So, how do you diagnose Paget's? X-rays of affected bones may be reflective of the underlying phases of the disease. For example, in the early osteoclastic disease, you'll likely see a lot of shaggy areas of radiolucency. Later on in the course of the disease, you'll see abnormally thick bone reflective of the increased osteoblast activity. Laboratory studies in patients with Paget's disease typically reveal elevated alkaline phosphatase levels, represented by our ALK-Phos chalk. That said, serum calcium and phosphate are generally normal, unless there's a parathyroid issue too. Generally, Paget's disease is mild and can be managed with medications like bisphosphonates and calcitonin. All right, that's it for osteoporosis and Paget's, 2 metabolic bone diseases with overactive osteoclasts. Oh, I get it. He uses the right arm for crab hunting and his left arm for kick punching his predators. Wow, the wonders of evolution.